Imagine walking into an emergency room and being examined by an artificial intelligence system. It asks about your symptoms, reviews your medications, orders blood tests and scans, interprets these results, recommends treatments, and finally decides whether you should be admitted to the hospital. That may sound like science fiction, or depending on your perspective, either a medical breakthrough or a terrifying idea. But a new Nature paper presents MIRA, an agent designed to carry out this entire process inside a simulated electronic health record system. In more than 500 retrospective patient cases, the system diagnosed selected conditions with an accuracy compared to, and in some cases higher than, physicians evaluating the same cases. So, has AI finally become a doctor? Well, not quite. And understanding why requires looking beyond these headline numbers. Over the past few years, we have seen many impressive demonstrations of artificial intelligence in medicine. Large language models can pass medical licensing exam, answer patient questions, summarize clinical notes, and this has been happening for last 4 plus years. But these tasks simplify what doctors actually do. A medical exam question usually provides all the relevant information upfront. A real clinical setting does not work like that. A patient may arrive with abdominal pain, fever, other symptoms. Each answer changes what should happen next. A doctor may initially suspect one condition, receive negative test result, revise the diagnosis and choose a different course of action. So clinical care is not one short question and answer task. It is a sequence of decision over a vast decision space. This is the gap the paper is trying to address. Instead of asking whether AI can name a diagnosis after receiving a complete case summary, the researchers asked whether AI could gather information itself, manage a simulated patient from first conversation through the final clinical decision. So, what is MIRA? The system developed by researchers stands for Medical Intelligence for Reasoning and Action. Importantly, MIRA is not a newly trained medical foundational model. Its main physician agent was powered by OpenAI's GPT-4o. The system also used an O1 preview reasoning model for a separate planning function that helps create structured multi-step clinical plans. But the real contribution of the paper is not simply through the choice of language model. It is how the researchers connected those models to a controlled clinical environment, in this case, the EHR system. MIRA operated inside Electronic Health Record Sandbox. It had access to 11 clinical tools and more than 85,000 possible actions or selections. It could interview a simulated patient, request physical examination, order blood tests, request radiology studies, reconcile medications, prescribe drugs, recommend procedures, and submit the diagnosis. Patient was also simulated by an AI agent. The patient agent was given information from a real de identified medical record and was instructed to answer MIRA's questions using the information available in those records. This created an interactive consultation. MIRA could not simply read and complete the chart and jump to the answer. It had to ask questions and decide what information is needed. The system also used established healthcare standards such as FHIR, ICD, LOINC, RX norm, SNOMED CT. These standards help represent diagnosis, laboratory tests, medications, and clinical actions in a structured format that healthcare system understands. And MIRA's actions were constrained. It could not simply invent a test or create a medication order in unrestricted text. It had to select valid actions and provide valid parameters through the tools. That distinction matters because a large language model that writes a plausible medical recommendation is very different from a system that must translate that recommendation into valid, structured clinical action. Let's talk about study design. The researchers evaluated MIRA using 574 retrospective patient cases taken for MIMIC 4, a large database of de-identified hospital records. The cases represented 8 conditions. Those conditions can be seen here. These were not completely open-ended emergency room encounters. The researchers selected cases in which the main diagnosis was known and the information considered necessary to reach that diagnosis was available in the records. For part of evaluation, MIRA was compared with human physicians. One group included 4 board certified doctors. Another mixed seniority group included 4 residents and 2 board certified physicians. These physicians interacted with the same simulated patient and operated under same information constraints. That makes the comparison more meaningful than giving the AI complete medical record while asking doctors to work from a short summary. However, the doctors were still using an unfamiliar research interface rather than working in their normal hospital environment with nurses, support staff, colleagues, and other experts. That limitation becomes more important while interpreting the results. Let's talk about the headline results. MIRA's diagnostic accuracy. Across 574 cases, MIRA produced the correct diagnosis in approximately 89% of the cases. In the matched comparison involving 311 patients, MIRA achieved an accuracy of 88%. The board certified physicians achieved approximately 78%, and the mixed seniority physician group achieved around 71%. But this does not mean that AI has now been proven superior to doctors. A more accurate statement is, in this specific simulation, across 8 selected diagnoses and under studies constraints, MIRA produced more correct primary diagnosis than the participating physicians. The researchers also examined how MIRA gathered information. The system tended to follow recognizable clinical sequence. Take a patient's history, form initial plan, request examination findings, order lab test, request imaging, and recommend treatment or admission. Now let's talk about what the headline might miss. At first glance, it is tempting to summarize this paper by saying AI outperforms doctors in emergency room. But that would be misleading. First, no real patient was treated by MIRA. The entire study took place in a controlled simulation using retrospective medical records. MIRA did not face a distressed patient who might forget important details, or change their story, or speak through an interpreter, or had multiple conditions at the same time. The simulated patient was grounded in relatively organized written history. Real conversations are much messier. Also, the study covered only 8 diagnoses. Emergency department encounters thousands of conditions, including rare diseases, trauma, psychiatric emergencies, pregnancy-related complications, and more. Strong performance across 8 selected conditions does not demonstrate general medical competence. Also, the cases were curated. The researchers excluded cases that lacked information physicians considered necessary to make diagnosis. But the incomplete information is one of the defining features of a real clinical setting. Additionally, the physicians' comparison group was small. Only 4 board-certified physicians participated in the main expert comparison. Doctors in real hospital collaborate with support staff, so their performance cannot be fully represented by a single person interacting with a simulated patient. Next, the underlying data came from one academic medical center and represented a care delivered between 2008 and 2019. Clinical practice, available treatments, and documentation patterns change over time and differ across hospitals and geographies. These researchers also could not completely rule out the possibility that some of the related medical data influence the commercial language model during training, meaning it is entirely possible the data leakage happened, as Mimic 4 is one of the very popular dataset in clinical field, and GPT models, the OpenAI models that were trained, might have seen part of this data or entire data. And finally, diagnostic accuracy is not the same as improved patient outcomes. The study did not test whether MIRA reduces mortality, shortens hospital stays, improves recovery, or makes patients feel better cared for. So the findings are impressive, but they should be understood as evidence from an advanced simulation, not proof that an autonomous AI agent is ready for deployment. So let's talk about what MIRA really represents. So let's talk about what MIRA really represents. Is it beginning of autonomous AI doctor? I think that description goes too far. This study took place in a controlled simulation, used retrospective data, covered only 8 indications, and relied on AI generated patients rather than unpredictable conversation with real people. But dismissing the paper because it is simulation would also miss an important point. MIRA demonstrates a transition from AI that is capable of answering medical questions to a clinical workflow, gathering information, requesting tests, interpreting results, translating all of that into structured actions inside an electronic health record environment. The most realistic near term future is probably not an AI replacing physicians, but acting more like support system to make right decisions.